Now I'd like to introduce Stephen Duckett, Dr. Stephen Duckett, our first speaker. Dr. Duckett is Health Program Director of the Grattan Institute and Deputy Chair of the Northern Metro Medicare Local. His experience and insight has been and continues to be essential in shaping the role of the Medicare Local in the Northern Melbourne community. Dr. Duckett doesn't need an introduction, but I'm going to introduce him anyway, so there you go. Dr. Duckett has held top operational policy leadership positions in healthcare in Australia and Canada, and he is here today to talk to us about the future of Australian healthcare, including Medicare, primary health hospital reform, as well as PIR, and you know, the future in that space. Stephen is one of the foremost thinkers in healthcare in Australia, has a very high profile and is very influential in terms of the papers he puts together and the thinking he puts behind it. So I'm sure you'll join me in welcoming Stephen to the stage.
So I'm going to start, I've been asked to talk about some of the aspects of primary healthcare reform and where the system is going and so on. So I'll start by talking a bit about health expenditure. And so these data are about government expenditure, both Commonwealth and state, over the last decade, and looking at the increase in government expenditure over the increase in the size of the economy. And across Commonwealth and states, the fastest growing area of government expenditure is hospital expenditure, and then we have other areas, primary health care and so on. So one of the reasons government pays attention to health policy is that it is the fastest growing area. And within the health sector, hospitals obviously are the fastest growing, way above gross domestic product, and primary care and medical services are also fast growing. What's important in terms of health policy is the aphorism, where you stand depends on where you sit. And this shows the size of various government expenditure in 2010, 2011, about $40 billion spent on hospitals and so on. But what's interesting here is the dark bit is Commonwealth government expenditure, this bit is state government expenditure. So you see that if you're a state government, you spend a lot of money on public hospitals and a lot of money on community health services. If you're the Commonwealth government, you spend much more on medical services and medications. And so the focus of policy tends to be shifted and different, and the Commonwealth government spends almost nothing on community health services, for example, so it doesn't think much about it. So when you're looking at policy in this country, you've got to think about that the different sectors have quite different perspectives on what is important. So I was a member of what was called the National Health and Hospitals Reform Commission, a body appointed by the Rudd government in 2000, shortly after I was elected, and 2007. And as part of that, I developed this sort of a little schema to try and help the Reform Commission think about where we needed to change the health system and how the health system needed to change. And one of the areas that we recognised was that there was the system didn't have good national governance arrangements. There were Commonwealth state committees that often got paralysed in their working, and we needed to establish national governments, bodies that actually could take a national perspective. We also recognised that the health system itself needed to be built in terms of some of the ways it worked, and we also recognised the importance for integrating cross-cutting and underpinning programs and fleshing that out a bit. So that middle bit, we recognised the importance of building on the prevention and early detection work, Healthy Start, early childhood investment, how the primary medical care system worked, and this was for visits versus longitudinal and chronic conditions, including mental health services, but also local and regional stewardship, say, and this is one of the ideas that Medicare locals came from. And that was and then we fleshed that out a bit more in this sort of simple diagram about how we thought the whole health system should hang together and develop. Anyway, arising out of that, there was a national health reform process, and the Commonwealth and there were some bumps in the road where Rudd tried to negotiate something and didn't quite work out, and then Gillard negotiated something. But in the end, we ended up with a national health reform process, which started off by saying the Commonwealth states will work in partnership, nice word, to implement new arrangements for a national unified and locally controlled health system. So there was this idea of the new national structure, but really important was the locally controlled. And that was going to do a number of things: improve patient access to services and public hospital efficiency. It was going to increase the Commonwealth share of public hospital funding through an increased contribution to costs of growth, and it was going to improve transparency. And there are a number of other ones as well, but what you'll notice about this is the first three on the list are all about public hospital services, partly harking back to those earlier slides where I showed that public hospital expenditure was the fastest growing component of government expenditure. But then we move on to improving, number D, the fourth one, improving standards of clinical care, improving performance reporting, improving accountability, and eventually we get in number 8, improving local accountability and responsiveness to the needs of communities through establishment of local hospital networks and Medicare locals. And so the idea was part of the role of Medicare locals was about improving accountability and responsiveness. And secondly, they also improving the provision of GP and primary healthcare services through the development of an integrated primary healthcare system. So going back to some of the comments that Rod just made about how to shape and reform and improve local primary care services and so on. So these were what the objectives are. And of course, all of that sounds really nice, but this one is a corporate bullshit generator. And to some extent, that list we see could have been generated by something like this. This generates mission statements for organisations. The emerging, overarching, emotional impact expediently empowers it. Anyway, it's a random word generator. Anyway, so within that context, we've got to think about where does mental health care fit and what was happening there. This is a picture of the Sunbury Asylum. But the mental health care policy, in my view, is still shaped by the history and, to some extent, other aspects of where it came from. And institutional healthcare back in the 50s, 60s, and to some extent the 70s was still seen as a state responsibility. In Victoria, for example, we still have the separate mental health, large institutional mental health services, and it was seen, the patients in those services were seen as a state responsibility and not covered by Medicare. And I think some of that is still there. There was a bifurcation of responsibility. Serious mental illness was seen as a state government responsibility, and the rest was sort of Commonwealth and private and so on. Now that to some extent is a caricature, but I think that history there is still important. From about the 70s onwards, there was beginning to be integration of mental health services into the public hospital system, and so some of these lines of separation started to blur, although they're still, I think, present in many aspects. Mental health services then, and still to my view, is a Cinderella of the system that is to some extent ignored, and to some extent I think that's attributable to the low status of clients, and that affects the policy salience of mental health services. The mental health sector is obsessed with national policies that look great in print, but the actual impact of those policies on system change, I think, is very, very tenuous indeed. So you end up with relatively small amounts of money being allocated to these services, in line with these policies, and there's not been the same emphasis on trying to shift the system in line with the rhetoric. You've ended up with, partly associated with these policies, various Commonwealth schemes of high spending and dubious effectiveness, in my view. And then, of course, we've had the advent of the National Disability Insurance Scheme, which is a new way of providing community support, providing community linking and for people with permanent and significant disability, including, of course, people with a psychiatric disability. So that The NDIS is a joint Commonwealth and state scheme, but it significantly increases the Commonwealth responsibilities in disability care. And I think this program, Partners in Recovery, is to some extent part of the recognition. And if you look at what the Partners in Recovery is supposed to do, it's supposed to support people with severe and persistent mental illness with complex needs. And if you look at those two sets of words, you'll see a high parallel between what PIR is supposed to achieve and what the NDIS is supposed to achieve. And so it's going to be really interesting to see how the various siloed mechanisms that we see in the health sector, especially for people with severe illness and permanent illness, dovetail with the new NDIS developments. And I think the NDIS is going to transform the disability sector, and is already transforming the disability sector, and how it impacts on the health sector and how it changes the way we in the health sector think about things and deliver services is going to be quite interesting. Anyway, if you think about what policy is and what policy levers you have, obviously the aim of health policy, aim of any government policy really, is to change the behaviour of organisations, people, communities, and services and professionals. And there are essentially 5 top-down levers that you can use to achieve any sort of change. One is financial incentives and spending. That is, the government can actually set up new services, spend more money to try and change the way the system works, trying to create new organisations which do things differently. To some extent, Medicare locals are about that. There's some evidence there. The government can also use financial incentives to change the way the system works by putting different incentives in front of people or organisations. It can actually change organisational structures, establish new national bodies, for example, change laws. It can provide information, comparative data, to actually try and use the data to get people to change the way they do things. It can actually say things, what I call hortatory policy, using rhetoric, and the national mental health policies are a good example of that sort of strategy, as I said, whether they're effective or not. And of course you can try and shape and change culture and values, often through educational strategies, often through the way professional organisations work and so on. It's really helpful if all of those levers work together and go in the same direction. That's of course not always the case. I remember when I was working in the Victorian Department of Health, my job was to regulate and limit the number of CT scanners and PET scanners and magnetic resonance imaging scanners introduced into Victoria, partly because the government of the day thought that the more of those that came into the system, the more expensive the system would be, the less money there was going to be for something else. The Commonwealth, on the other hand, had a set of financial incentives that encouraged the growth of CT scanners, and so the two sets of levers were working in completely opposite directions, and eventually the Victorian government repealed its regulatory controls because the Commonwealth wasn't the least bit interested in the work that was being done. So as you saw from the earlier slide that one of the objectives of the system, of the reform, was to create a unified national system with local accountability. And the essence of the local accountability, in a number of states they had no boards of management of hospitals, but in Victoria we've had that for forever essentially. And the idea was that there'd be these two local organisations, on the one hand the local hospital networks and on the other hand the Medicare locals, which would have to some extent some commonality in terms of boundaries, and the idea was that they'd work well and closely together. That has to some extent, there is a naive view that hospitals and local hospital networks sort of have boundaries. It is indeed a naive view, but the idea would be, for example, that in this area, for example, Northern Health is responsible for some parts of the area, then Austin Health is responsible for some other parts of the area, and the boundaries of the Medicare local would somehow or other relate to the boundaries of Northern Health and Austin Health. But in Victoria, those organisations, Northern Health and Austin Health, are not population-based organisations. They don't have boundaries, and in fact people who live a bit to the west of here travel to the Royal Melbourne, for example, for hospital care. It's the most convenient place, and so you don't end up with a very easy mechanism for that to occur. But to the extent it can, it does, and we have representatives of people from Northern Health and Austin Health involved on our working parties, and indeed the chair of the Northern Health Board is a member of the board of the Northern Melbourne Medicare Local. But these two things were the focus of the National Health Reform, and what's really interesting about that is it leaves out everything else. Everything else includes specialist services, specialist physicians, surgeons and so on, but it also leaves out everything else in terms of primary care services, community health centres, Aboriginal controlled community health organisations, home and community care, housing, education and so on. And so, in a sense, the design of the National Health Reform explicitly excluded from its considerations anything to do, for example, with the social determinants of health and anything to do with what was in this community health and Aboriginal health sort of area. So it was a really quite a peculiar way of thinking about it, and if you of what the health system is and how ill health is created. And so that was ignored. So in terms of those 5 top-down levers I was talking about, the Medicare locals, there was a lot of rhetoric about the Medicare locals. They were going to coordinate health services and so on and so forth, really big on rhetoric. It's important to remember that the Northern Melbourne Medicare Local has a budget this year of about $25 million a year, or for this year, whereas the total spend on health services in this area is about $5 billion. So that the influence of a $20 million organisation on a $5 billion health system is necessarily going to be small. I wouldn't say it can be totally ignored, but it's really, you've got to understand that the achievements have to be seen in line with its ability to influence. So big on rhetoric and small on dollars. Of course, the Medicare locals were an organisation. There was also an alphabet soup of superstructure created, organisations called NIPA, IPA, AMFA, so the National Health Performance Authority, the Independent Hospital Pricing Authority, the Australian National Preventive Health Agency, etc., etc., etc. Organisational structure. In terms of financial incentives, big changes to the way the Commonwealth interacts with public hospitals. So for the first time, the Commonwealth Government is exposed to the costs of growth of public hospital activity. Until today, for example, the money that Victoria gets from the Commonwealth Government for health services is not affected 1 cent if there is an additional hospital admission in this state. It's entirely based on essentially history, that is population formula, but the way it's now described is somewhat different. Come the 1st of July, though, if there is an additional patient treated in a Victorian public hospital, then the Commonwealth shares the cost of that additional patient to the tune of 45% of what's called the national efficient price. So there's a price list that covers all public hospital services, and if there's an additional patient in the 2014-2015 year over and above the 2013-2014 year, then the Commonwealth pays 45% of the cost of that additional patient. And importantly, the price list for public hospital services covers not only inpatient activity but outpatient activity, and that includes a lot of the community mental health services in this state are defined as public hospital services for the purpose of that payment. Information provision. The National Health Performance Authority publishes comparative data, including data about public hospital services, the length of stay, for example. It's going to publish later this year information about the efficiency of public hospitals, and it names them and ranks them and so on. But it also publishes information about community services such as the immunisation rates in this particular Medicare local area. So going back to that rather complex diagram about what I was trying to show, there's lots of change that needs to occur. And for example, with respect to mental health services, we need to be thinking about what can be done in terms of prevention to create healthier communities which would support community resilience in terms of prevention and early detection. We need to be thinking about how do we improve primary care visits for in and out of hours, how do we actually strengthen the ability for the primary care system to deal with mental health services, how do we actually strengthen the community to deal with people with complex and chronic conditions. Here that box says something like enrollee access complex and chronic conditions. Now importantly, the government didn't actually pick up on many of these recommendations when it responded to the National Health and Hospitals Reform Commission report, and so the problems are still there. We identify our solutions, our recommendations may not be the right recommendations, but we identified following extensive community consultation a whole set of problems in the system, and by not picking up on our recommendations and not putting any other recommendations in place, they left the problem sitting there, and including this problem of how do you shift a primary care system away from episodic payment and responding to single visit sort of medical services into looking after people over a year or over a longer period, looking after people with chronic illness. And as I said, the government didn't respond to that, so it leaves the problem there. Another issue that has been by and large left unaddressed is this question of how do you help people in their critical transitions over the life course, moving from young kids moving from home into out of home, moving from school with a particular set of environments to either work or tertiary study. How do you help people move from work into retirement and so on? And in particular role for the Medicare locals is this issue about how do you improve the interface between the primary and secondary care system and between the acute and the aged care sectors. And so one of the problems we have in our system is the discontinuities that occur, that we don't have a joined up system, we don't have easy transitions between the various sectors, and it's one of the particular issues that the Medicare local wants to work on. And finally, this whole issue of consumer empowerment, experience, information and advocacy programs, particularly important in areas like mental health, where there's been a long tradition in Victoria of advocacy, but how do we help people manage their own conditions and so on. So what's critical about all of this is there is not one quick, simple fix to this. You cannot expect one policy instrument to be able to address all those issues in mental health services or in any other particular area for that matter. And so what we need to be thinking about is multiple strategies to try and shape the system and reshape the system. And as I said, these issues are still with us. And so when you hear, for example, of, if you look at the debate over the last 3 months, the single most common way in which the health sector has been discussed in terms of policy over the last 3 months has been about a $6 co-payment for general practice services. Well, of course, that is, I won't say trivial, but it's not really the main game in terms of any of these issues. And so even the advocates of the $6 co-payment, for example, would say that it will generate $180 or so million a year. That saving will, of course, evaporate if people shift from going to see a GP to going to a hospital emergency department. If just 1 in 4 or 1 in 5 people, instead of going to a GP, go to a hospital emergency department, there's no savings to the Commonwealth at all and significant additional costs to the state government. But even setting that aside, $180 million sounds a big amount of money to the Commonwealth, but if Australia paid the same for drugs on the PBS as England or New Zealand or Canada, or the province of Ontario in Canada, we would save $1 billion a year. So it's 5 times as much just by changing our ability to purchase pharmaceuticals on the PBS. So I'll skip that. That's sort of what we're looking at. But no, I won't. So the Grattan Institute, we've established, which is my day job, we've established a health program, which isn't very large, but we have 2.5 people working from Grattan Institute on this. We get other people on secondment. But some of the issues we're concerned about are waste in the system. That is, can we make savings that don't impact on access to care and so on, and use those savings to actually address some of the other issues. We've got also issues like prevention. Obviously, prevention is an important issue. We're not immortal, but we want to actually make sure that the lives we live are good lives. And we want to improve life expectancy. There's been a significant increase in life expectancy over the last decade or so, but half of that increase, for people over 65, half of that increase has been years lived with a disability. And so we are living longer, but for 6 months of every year of extra life, we're actually got some form of disability. And so we obviously want to improve the years lived in good health. And how do we do that? And then when you think about prevention issues, including prevention in mental health, you've got to think about whose lives are foreshortened, for example. And there was an article in a online newsletter called The Conversation, which talked about rural health issues. And rural health issues are pretty important. And if you think about it, people who live in rural Australia, rural and remote Australia, have much less access to health services than people in metropolitan areas. And what they talked about was the significant difference in life expectancy between people in rural Australia and people in metropolitan areas. And it is quite significant, about 6 or so years difference, maybe 7 years difference in life expectancy from remote and metropolitan areas. The article didn't mention the word Indigenous at all. And what's important about that is that by and large the difference in life expectancy in rural and remote Australia compared to the metropolitan areas is driven by differences in the life expectancy for Indigenous Australians. And so, for example, I think the difference in life expectancy for a non-Indigenous person in remote Australia is a few years from the metropolitan, but the difference for a Indigenous person, I think, is 17 years compared to the metropolitan average. And so you've got to think about whose lives are being foreshortened, and people with mental illness, serious mental illness, have much shorter life expectancy than the rest of the population. So, what policies can we adopt to improve life expectancy or reduce the future burden of ill health? And that is really quite a complex issue. Similarly, what do we do about access? How do we improve access, and so on? So these are some of the critical issues which are unaddressed, and of course the $6 co-payment doesn't address any of those. And what does the Northern Melbourne Medicare, how does the Northern Melbourne Medicare Local fit into all of this? Well, we're in the middle of developing our strategic plan, and some of you might have been involved in that. But there are essentially 6 pillars to the plan, or platforms or something, platforms and pillars maybe. And obviously the goal of the Medicare Local is to lead and influence services, and as I said, we're a very small budget item in the total spending. So sometimes you see language along the lines that the Medicare Local is to coordinate services. I hate that term because we don't have the ability, we don't have the funding and so on to coordinate services. What we can do is try and influence and shape the system. So that's critically what we are trying to do. And in what way are we trying to shape the system? Well, we're trying to build locally responsive and relevant care. We're trying to actually develop integrated care pathways to address this issue of seamlessness between primary care and acute care, for example, and between mental health services and general health services and so on. We're trying to create empowered individuals and communities, and we've got a number of strategies about that. So that's what we're trying to do, and amongst other things, we want to have highly skilled and capable service system to achieve all that, and strong governance and effective management of the organisation to achieve that. So that's essentially how the Northern Melbourne Medicare Local sees itself fitting into those directions.